This is a right shoulder in a 17-year-old female with symptomatic multidirectional instability and Ehlers-Danlos syndrome. Her laxity in all three directions is clearly evident on the evaluation under anesthesia, as are other signs of hyperlaxity.
Intra-articular pathology usually consists of a patulous rotator interval, a normal labrum, and articulating surfaces, as MDI is a capsular pathology. Chronically, there can be some labral damage, as you can see posteriorly in this case. The drive-through sign is also markedly positive.
Viewing from an anterior superior portal and working through both the anterior inferior and posterior inferior portals, the capsule is thoroughly prepared with the rasp, taking care not to injure the attenuated capsular tissue. This promotes soft tissue scarring and healing.
The first plication stitch addresses the primary direction of instability, which is inferior, a common finding in all symptomatic multidirectional instability cases. A pinch tuck technique, as described by Snyder, is utilized. The tissue is pierced approximately 10 millimeters from the labral edge, capturing and exiting the inferior pouch, followed by a passage of the suture hook through the intact labrum. A PDS suture is used as a shuttling device to retrograde a non-absorbable, high-strength suture through the labrum in a horizontal mattress configuration. Non-sliding knots are tied so as to not abrade the attenuated capsular tissue. With this technique, the labral height is reconstituted, the capsule reinforced, and a barrier to inferior instability is achieved. Here we demonstrate the reinforced inferior labrum buttress, which is stable to manual stress.
Anterior instability, which was the next most prominent finding on the examination under anesthesia, is addressed with the same technique at the 5 o'clock position. If there is difficulty passing the stitch through tissue, a probe from the opposite portal providing countertraction may be helpful. A dilating knot tied in front of the knot advancing the suture can also help with suture passage. In order to balance the capsule, a horizontal mattress suture is also placed at the 7 o'clock position with the pinch tuck technique in a horizontal mattress configuration. The sutures are placed away from the articular margin to avoid articular abrasion. In this case, the posterior labrum is frayed but still intact and should be adequate for the plication. If the labrum is compromised, suture anchors should be utilized.
At this time, additional sutures are placed both anteriorly and posteriorly to balance the capsule. Absorbable sutures can be utilized at this juncture with an effort to decrease the drive-through sign by at least 50 to 75%.
A rotator cuff interval closure is recommended. The coracohumeral ligament, as part of the leading edge of the supraspinatus, should be captured with the closure. Using the PDS suture, a permanent suture can be shuttled through the rotator interval and the interval shortened, providing additional stability.
At the completion of the procedure, side-to-side sutures are placed through the posterior portal to prevent a stress riser risk to posterior capsular tearing. This completes the arthroscopic capsular plication procedure.